Hi, it's Tom here from Running Physio. Today, I want to talk to you a little bit about patellofemoral joint loading and how we can adapt it with some simple strategies to reduce pain during rehab. And we're going to reflect on some brand new research on this area and have a look at some of the loads the knee's exposed to during various activities in this video. Before I jump into that, I do want to let you know we've got a great selection of free videos available for you over at Clinical Edge. So I've put a link in the title there for you. We've got videos on iliotibial band syndrome, Achilles tendinopathy, lateral hip pain, lower back pain. Do check those out if you haven't already. They're all free, they're all evidence-based, and I'm sure they'll really help you in clinic. Now, as often with these, I want to talk to you about some research and how it's going to integrate with clinical practice. And there's a brand new paper out by Hart et al. In the British Journal of Sports Medicine, and I'm going to link to that in the comments later. I do recommend checking that out. It's a good new paper. And what this did is it's a systematic review looking at patellofemoral joint reaction force, which is one of the measures of stress on the patellofemoral joint during everyday activities and rehab activities. And they looked to see whether that was any different between individuals with patellofemoral pain or patellofemoral OA and healthy individuals. So we're going to explore some of the findings from the research in this video and talk about how we can use some of their findings in clinic. Now, there's loads of different terms out there describing some of these biomechanical measures. So I think let's start by dipping into what this phrase means, patellofemoral joint reaction force. Now, this paper, as I said, it's excellent. They have a nice description of it in the paper. So they say the tension in the quadricep muscle and patellar tendon drives the patella against the surface of the distal femur, creating a reaction force, the patellofemoral joint reaction force. So that's quite a nice description of it. And that brings us to our first key point from this, which is they think that this patellofemoral joint reaction force is largely going to be increased by two things. So one, the demand on the quads, and two, the amount of knee flexion we're loading in. So if we want to reduce this joint reaction force, we can either reduce the demand on the quads or we can load in less knee flexion. And that potentially then can have a knock-on effect of helping symptoms. Now, there's an important kind of other side to this that they talk about in the paper as well, which I think is important to understand, which is joint contact area. So how large a surface area these stresses are spread over. Now they describe this really nice in the paper. They say in a normally aligned patellofemoral joint, activities involving high knee flexion do not necessarily translate to excessive patellofemoral joint contact pressure, as the contact area increases with knee flexion angle. So we've got a slightly different term in there, contact pressure. So if we're increasing knee flexion, because there's a larger surface area to spread the load out over, we don't necessarily see increased contact pressure. Now, notice at the start of that, they say in a normally aligned patellofemoral joint. Now, what does normally aligned mean? I mean, we know obviously there's a bit debate about what is normal out there. But what we think is if someone is loading their knee with increased hip adduction, possibly with more hip internal rotation, that there's going to be an increased load on the lateral part of the patellofemoral joint. So we may see the surface area reducing, perhaps that we're having more pressure on a particular part of the patellofemoral joint, which may then lead to overload and symptoms. So perhaps then in some people we see a combination of things happening. We see them loading in deeper knee flexion combined perhaps with increased hip adduction. So we see an increase in the reaction force, and we see that force spread out over a smaller contact area, perhaps focused more on the lateral part of the knee, which overloads it and leads to symptoms. Now, hopefully you can appreciate this is all very mechanical, isn't it? It's all, let's just think about load, let's just think about tissues, and that's all that matters with pain. But this does seem to be something we see in runners. Runners that tend to overstride will often have a low step rate and will load in deeper knee flexion when they get to the mid stance point of running where the stress on the knee is at its highest. And they'll often accompany this with increases in hip adduction, particularly in my experience, perhaps more in female runners. So this may be a piece of the puzzle for why they get pain, because they're loading the knee in a position that's going to be potentially a bit more provocative. So these are interesting ideas in terms of what may increase some of these stresses on the knee. The next question is, well, what can we actually do about it clinically? What can we take home from this? Well, we can think about the different activities that stress the knee and perhaps use a graded exposure to those activities, gradually increasing the stress on the patellofemoral joint. And they summarize the findings in their systematic review by giving us approximations of what these stresses will be in healthy individuals. So we see here in the graphic on the screen, walking, for example, patellofemoral joint reaction force, 0.9 times body weight, so just under body weight. Stair descent, going down the stairs, 2.8 times body weight. Stair ascent, a little bit more, 3.2 times body weight. And then running, 5.2 times body weight. Now, I believe these are averages of the studies that they include in the systematic review, and there was a lot of variation in here because it would depend on, for example, how fast you run. Then for other activities, there was a big variation in the study findings, again, because they're going to vary based on the load, based on the range, etc. So squatting, they found that joint reaction force could be between 1 and 18 times body weight. Huge variation there. Similar with lunge, 3 to 6 times body weight. Cycling, 1 to 7 times body weight. And jumping generally a bit higher, 9 to 11 times body weight. So what we could do in our rehab is think through a graded exposure to load on the joint by working gradually up through these activities. And I think while we might try and do it very scientifically based on load, we're probably more often than not going to do it based on symptoms. What's the symptom response like here? Because we know load and symptoms don't correlate perfectly, but perhaps we get the patient to tell us what are their valued activities that they want to get back to. That's really important. What are their goals? And we sit down and we think what is likely to be the most manageable for the knee, and we start building that first, and then we start progressing through the more challenging activities, easing them back in to what they want to do. So one part of this might be graded exposure to more challenging activities. Another part might be around modifying our rehab exercises to reduce the stress on the knee joint. So if you think, as we said, that this joint reaction force is going to be increased with increased knee flexion, do we look at perhaps squats in a shallower range, like 0 to 90 initially? Leg press perhaps in a shallower range, 0 to 90 or less initially, as a way of reducing the stress on the joint, and again being guided by symptoms. Do we perhaps recognize that things like lunges are going to be challenging for the knee because they're loading into flexion ranges and adapting those ranges too? Could we look at perhaps the technique used for these things if we think an increase in hip adduction is going to be part of it? So perhaps try and just adjust the technique slightly so there's less hip adduction in squats, single leg squats, lunges, stair ascent and descent, etc. So we can look to adapt the exercises and rehab for less stress on the joint and less symptoms. And we can do a similar thing with running and plyometrics. Now, there's quite a number of studies now that show if you increase the step rate, so your cadence, the total number of running steps per minute, it reduces the stress on the knee. Now, this is because it reduces knee flexion, and it also reduces the peak demands on the quads. So it's addressing those two main kind of components of patellofemoral joint reaction force. Plus, an increase in step rate tends to reduce peak hip adduction as well. So that is a simple cue that we could use intermittently for runners, which is likely to reduce the stress on the knee and help improve pain. We may go a similar approach with plyometric activities like jumping. Do we look first of all to emphasize a short ground contact time? So get the person to imagine they're jumping on hot coals for their plyometrics. Because if you're in contact for the ground for a shorter period of time, there's less time for you to go into deeper knee flexion where you're likely to get higher patellofemoral joint reaction forces. So we can look to try and tweak and adapt our rehab, probably largely by reducing the knee flexion ranges, perhaps by reducing the ground contact time as well as part of that, and looking at hip adduction as ways to adapt the load upon the knee. And as ever, we're going to be guided largely by symptoms. Now, it's important with this, as I've touched upon, that we don't get too obsessed with load and see this purely from a mechanical model. In patellofemoral pain, there is evidence that psychosocial factors play a role. There's evidence in runners to show hyperalgesia, perhaps signs of central sensitization, which seems to be linked to training volume. So it would seem that the more a runner is training, the more hypersensitive the knee is going to be to load, which may mean that activities with a lower stress on the knee are now becoming painful. So we may not need to change movement to see improvement. We might just need to adjust training volume to make the knee less sensitive to those loading activities. Or we may need to help the person to understand that that pain is not a sign of damage to reduce the threat value that they associate it with, and perhaps reduce pain there by altering how those sensations are interpreted. So there's lots of different ways that we might be able to approach this problem. Maybe we don't choose to change the movement pattern itself. Perhaps we have someone who's particularly anxious about their knee, which is understandable, particularly focused on the biomechanical aspects and alignment and moving right. And actually, sometimes in those patients, it may be more appropriate to move away from that to reassure them that the movement pattern they choose for themselves is absolutely fine, and allow them to move without really too much thought and concern to how. Whereas with other people, if it's very much load-related pain that improves quite dramatically with a small change in the movement technique, we may be more inclined to make a small change to how they move, at least in the short term, to help things settle. So we've got quite a few different options available to us. And we've got to remember too, as we've talked about, that if you want to reduce the load on the knee, the training variables are going to make a dramatic impact on this. And there's evidence to support this from J.F. Esculier et al.'s work in patellofemoral pain. Just educating someone around load management and bringing the training down to a manageable level on its own, without any additional treatment options, without trying to do gait retraining, without trying to change how someone moves, has been found to improve pain and function in those with patellofemoral pain. So I still feel that's probably the priority option, but it would be worth considering. Do you want to reduce knee flexion? Do you want to address hip adduction? Do we want to try and change some of these other things that are going to reduce the stress on the knee for this patient and therefore have a knock-on effect for symptoms? Okay, so I hope you've found that useful. As I said, I'll put a link to this Harter tool paper in the comments. I do recommend checking out our free videos. We've got lots of those available for you if you want to learn more about running injury. If we're going to try and sort of really summarize this paper and the thoughts on reducing patellofemoral load, I would say probably our main ways of reducing the stress on the joint will be load management, but also reducing knee flexion during loaded tasks like squats, leg press, and running gaits, and potentially reducing hip adduction if that's excessive. But more than anything, we're going to be guided by symptoms, and we do want to gradually re-expose the knee to more load over time to get it used to it. Okay, thanks again for listening today. I look forward to your comments and questions, and I'll speak to you all again very soon. Bye for now.